Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. Today's episode features three experts in the field. Dr. Stephen Cantrill, recently retired medical director at Denver Health Medical Center. Dr. Raj Gandhi, an infectious disease physician at Massachusetts General Hospital. And Dr. Payal Patel, system-wide director of antimicrobial stewardship at Intermountain Health. Listen in as these experts discuss the risk factors associated with progression to severe COVID-19 and initial workup to classifying disease severity, all of which is centered on a detailed patient case to illustrate key takeaways. This episode is part of a larger educational program titled COVID Rounds, Clinical Case Discussions on Best Practices for Inpatient COVID-19 Management. For more information on Drs. Cantrill, Gandhi, and Patel, along with a link to the larger educational program, please visit the link in the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Welcome, everyone. Today's COVID rounds, we're going to be talking about inpatient COVID-19 management of people with mild COVID-19. So now let's turn to a case. This is a person with COVID-19 with mild to moderate disease, but who's hospitalized. So this is a person who's 78 years old. They have a history of lymphoma. They've received rituximab as well as other chemotherapy for their lymphoma in the past 3 months. And this individual presents to the emergency department with right hip pain after a fall. They also report fevers, myalgias, cough, and some other upper respiratory symptoms that started 2 days prior to this fall. And when you see this individual, the blood pressure is 140/85, the heart rate is 96, respiratory rate is normal at 14, temperature is 38.2, and importantly, the oxygen saturation on room air, on ambient air, is 95%, so normal. Physical exam is notable for a right leg with significant external rotation and shortening. And in terms of vaccination and prior COVID status, this person had 2 mRNA COVID vaccines 3 years ago, I should say 2 doses of the mRNA vaccines 3 years ago, but has not had any boosters since. Did have COVID-19 about 2 years prior to this admission. You do a COVID test and the antigen test is positive. So the person is admitted for their broken leg, but also has signs and symptoms of COVID and is testing positive for COVID. And now over to my colleague.
Thank you. Yeah, I'm going to go through some current trends in SARS-CoV-2. This is a most recent capture, but if you're interested, the CDC COVID tracker is still live and they're updating that twice a week. One thing that I would highlight from the infectious disease background is that all current variants that are really in play here are Omicron related. And so the vaccines that have been updated have been in terms of the Omicron. And so I think that's really important. We were seeing a lot more changes early when COVID had first come out. And so that's something to think about. The media often talks about this too, but deep in those newspaper articles are that these are all Omicron subvariants. I think that's really important to keep in mind. Just noting what has been happening with hospitalizations, and actually along with this mortality trends are very similar as well. Those are also continually being updated on the CDC COVID tracker website if you want to see latest trends on those. Thinking back to 2019, 2020, and then again looking at 2021 and those hospitalizations, and then bringing us to where we are now. That's basically the lowest amongst the hospitalizations. And so we've definitely seen an improvement in hospitalizations and mortality associated with COVID-19. I'll hand it over to Dr. Cantrill.
Thank you very much. We're going to discuss now the initial workup in the emergency department when presented with a patient who may have COVID-19. This is the case that we've already been discussing. Obviously, in this case, in reality, the patient usually comes in without having a test that's positive. And our goal is to determine which patients are going to require hospitalization and those that we can treat in the ED and then release with follow-up. Follow-up was extremely important, especially during the initial onslaught of COVID-19, because we weren't really sure what we were dealing with. So we have that information. We're going to do standard H&P in this patient, including the risk factors for progression to severe COVID-19. Then laboratory testing we've touched on briefly, certainly an antigen test or the nucleic acid amplification test. And it's important, as seeing this patient initially, that we realize there's a 5-day window in which the actual test can be negative, but the patient can, in fact, have COVID-19. So a negative test means it's negative only at that instant and does not mean the patient does not have COVID. Very important to remember. We'll do a CBC kind of standard and a complete metabolic panel, and then any other labs as indicated by other comorbidities the patient may have. In terms of imaging, not everyone would get a chest x-ray if it was truly a very mild case. But if you're concerned or if the patient has risk factors, go ahead and get a chest x-ray. Or if they're severe or critical, you may want to get a chest CT, an EKG if indicated, and then any other studies that may be indicated. In terms of the NIH severity classification, mild, moderate, severe, and critical, and our patient falls into the mild. She has a fever, she has cough, she has muscle pain, and her O2 sat, importantly, is 95. It would fall into the moderate classification based on clinical assessment and imaging, but with a normal, essentially a normal O2 sat, 94 or above. Severe would be an O2 sat less than 94, or their PaO2, FiO2 ratio was less than 300 millimeters of mercury, or their tachypnic to a rate of greater than 30, or their lung x-ray showed infiltrates in more than 50%. And then obviously the critical, anyone who's in septic shock, respiratory failure or multi-organ dysfunction. Now, just a note about pulse oximetry. It can be a little misleading. It can be offset by skin pigmentation, skin thickness, and skin temperature. And it's also important to note that many of the portable single-digit pulse oxes that you can buy in a drugstore or through mail order have not been FDA approved. And even though some of them have been cited because they state they're FDA approved or they're not. So you should certainly calibrate any pulse ox that you use at home. In terms of death risk ratio, age is the strongest risk factor you're dealing with. If you are 65 to 74, you have 6.7 times the risk of death from COVID-19. Less so with some of the other comorbidities. Here's top is obesity, 1.3 times, chronic kidney disease, and on down to heart disease and other comorbidities. The slope of that curve based on age. So we pay a lot of attention to age in terms of assessing what the patient's risk for further development of the disease process. Now, this patient, again, has hematologic malignancy, and she's on immunosuppressive medications. Those are also indications of higher risk. And then you have some with the suggested higher risk and some with mixed evidence. This was put together by the CDC and is actually quite helpful. In the ED, some places have used something called the PRIEST score, Pandemic Respiratory Infection Emergency System Triage, or PRIEST. And it's very nice because it doesn't require any lab test. It requires some historical data and vital signs, and that's really it. And this has been validated. Now, one caveat, this was developed and validated before we had good treatments for COVID-19. So in the patient that we presented, she'd get 1 point for her respiratory rate, 1 point for her O2 sat, 1 point for her heart rate, 1 for her temperature, and 3 points for her age. So this would give her a total score of 7. And based on this, it would be an 18% chance of disease progression in this lady. So again, it can be very helpful, especially if you don't have rapid access to testing. So what we've got in this lady, her antigen test is positive. CBC and CMP were unremarkable. Chest x-ray was clear, and her x-ray of her pelvis and right hip shows a greater trochanter fracture on the right. So certainly she'll be admitted to the hospital. And then what are we going to do? Raj, do you want to take this?
Yeah, I mean, I'd like to pick up where you left off on the risk factors for progression. Certainly the graphic around age is very, very dramatic. A lot of that data did come from the first year of COVID-19. I think the cutoff for that particular study was March 2021. So it was even before we had widespread vaccination. That being said, the part that really impresses me is that even today in 2024, the majority of people who end up in the hospital are people over the age of 60 or 65. And so even though the risk has fallen, as Dr. Patel showed us, substantially, nevertheless, age continues to be a large contributor to our hospitalized as a risk factor for hospitalization. I do want to also say that COVID vaccine status, there's no doubt that vaccination prevents progression to severe disease. And that's true across the board, whether you're younger or older. But immunocompromised people still, I think, and this patient was certainly counted that, don't always mount an adequate immune response. Now, this patient has two strikes against them. One is the last vaccination was well over 2 years ago. So certainly antibodies wane. T cells, perhaps not as much, but antibodies wane. And then the other strike is the rituximab really makes the antibody response, as Dr. Patel highlighted, suboptimal. So maybe I'll see how Dr. Patel thinks about this person.
Yeah, I think, I will shout out to antimicrobial stewardship programs, throughout. This is something that has come up in the last few years where they're admitted for something else completely unrelated to COVID-19, in this case for a fall, and then they're found to have COVID-19. And I think this is a place where, you might want to look at whether your institution has outpatient guidelines versus inpatient guidelines for COVID-19. When those are being formulated, we think about the patient in the ambulatory setting versus the inpatient setting. And if they're admitted for COVID-19, it's kind of a different case. In this case, I think I would kind of put those two together. One thing that we've talked about before is logistics. So there hasn't been necessarily head-to-head remdesivir versus the oral options, antivirals, but logistically, remdesivir can be challenging in the outpatient space, but easier to do inpatient. So that would be something I would be thinking about. But this would be a really good time really to think about what your institution is offering for the outpatient and inpatient, and then kind of combine them together in this case.
Yeah, and in that regard, you reminded me of a really important point. When these trials were done, they were either done in the outpatient setting or in the hospital. And yet this particular patient that we're talking about, had she not had a trochanteric fracture, her COVID is probably such that she would be treated as an outpatient. So we have to in some ways extrapolate data from the outpatient trials that we'll talk about to this person. So that's just something to keep clear. It's really an interesting situation. It's fair to say that there's being in the hospital versus not being in the hospital, if you're not in the hospital for a particular COVID-related condition, shouldn't matter. And that's why we do these extrapolations. But the studies, they weren't divided that way. And that's why you'll sometimes see people, and sometimes it's called expert opinion because we're extrapolating from certain circumstances. So.
Let me just say one point about starting patients on antivirals in the ED. We feel pretty strongly about that. And the sicker the patient, the more strongly I feel. Sometimes the ED is very, very busy, and we can't get to that. But I feel it's quite important, especially in the severely ill patient, because there are so many delays built in to most institutions, unfortunately, getting the patient up on the floor, getting orders written, getting the drug from pharmacy. And if we can get the first dose going with the patient in the ED, I think that's a big plus for the patient.
Yeah, and I think that really touches on the importance of multidisciplinary care. The ED will stabilize the patient. Antiviral therapy, as we're about to talk about, works best if you started early, and then they'll hand off that care of that patient to either the surgeon who might be fixing the fracture or to an internal medicine physician, depending on what the primary service is. So yeah, I totally agree. Dr. Patel and Dr. Cantrill have talked a lot about the risk factors. Let's put this all together. And so we've already mentioned and talked a bit about age. And so age certainly, as we heard, is perhaps the most important risk factor. And when we mean age, as you get into your 70s and 80s and 90s, that's really when age becomes an important risk factor. Chronic medical conditions also play a role. And so we want to know if our patients have diabetes, do they have obesity, do they have other conditions, heart and lung disease, I would really put up there. If they have severe chronic obstructive pulmonary disease, if they have severe cardiac disease, that's going to increase the risk of a progression. We've mentioned rituximab several times. Immunosuppressive conditions or medications is a third dimension in terms of our patient's risk, with lymphodepletion, rituximab being prominent, but also stem cell transplants and hematologic malignancies. There are a couple of conditions that we sometimes think about as immunosuppressive that are less impactful. So, for example, TNF inhibitors in the big scheme of things are less likely to lead to progression than some of the other immunosuppressants we give. And so that's been learned over the course of COVID. And then in our patient, we talked about vaccination, but yes, there's no doubt that full vaccination plus boosting is going to put someone at the lowest risk. And so keep that into account as you're trying to decide whether to give antiviral therapy. Thank you for joining and look forward to seeing you again.
Thank you, Doctors Cantrill, Gandhi, and Patel, and many thanks to you, our listeners, for joining in. As a reminder to view the full program, COVID rounds, clinical case discussions on best practices for inpatient COVID-19 management, please click on the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.